Hi, my name is Sandy Takata, and I'm a PhD candidate in Dr. Sean Roll's research lab at the University of Southern California. Today, I want to talk to you about our research project using musculoskeletal sonography to analyze healing tissues of Zone 2 flexor tendon repairs post-surgery. Traumatic acute flexor tendon injuries of the hand occur often and is expensive to repair. Repaired tendons typically take about 10 to 12 weeks to fully heal, and in order to be successful, the tendon ends need to heal together with adequate tensile strength and have unimpeded tendon glide. One of the critical factors to tendon recovery is this timing of when to initiate motion. Movement that is too early risks the tendon rupturing, and movement that is too late risks the development of scar adhesions that limit range of motion. Currently, there are no precise measures of recovery for individualized rehab protocols to inform when to initiate this ideal timing of movement, thereby improving these patient outcomes. We know that musculoskeletal sonography can detect morphologic changes in healthy and pathologic tendons with biomarkers that correlate with immediate as well as long-term outcomes. As such, we believe it is the ideal modality to evaluate tendon healing with precision, facilitating patient successful and efficient recovery. So the purpose of our research is to develop a sonographic image acquisition and analysis protocol to evaluate the healing process of flexor tendons post-surgery. So we're using a 15 to 18 megahertz linear transducer and a Logic E portable ultrasound machine to identify the image acquisition techniques that maximize image quality of the small tendon structures. We also want to examine candidate image analysis methods by reviewing the literature and pilot testing these measures from healthy volunteers and participants with flexor tendon repairs. So this is a basic overview of the anatomy in the area of interest. We are mainly concerned with two tendons, the flexor digitorum superficialis tendons and the flexor digitorum profundus tendons, also known as the FDS and the FDP. So the FDP and the FDS tendons are responsible for bending our fingers. The FDP tendon lies deep to the FDS tendon and superficial to the proximal, middle, and distal phalanges. As you can see on this diagram, the FDP tendon is shown in red. The FDP tendon inserts on the distal phalanx and is responsible for bending the tips of our fingers or the distal interphalangeal joint. The FDP tendon lies superficial to the FDP tendon along the same line of pull. However, the FDS tendon, seen in yellow, bifurcates the proximal phalanx and inserts on the lateral aspects of the middle phalanx. It is responsible for bending the proximal interphalangeal joint. So when we use sonography to look at these two tendons, we can see the FDS and FTP tendon in both longitudinal and short axis view over the metacarpal phalangeal joint. So that joint that bends your knuckles. In the longitudinal view, the FDS tendon lies superficial to the FDP tendon, and you can see the tendon fibers running left and right across your screen. And at the bottom there, we have the proximal phalanx and the metacarpal head meeting each other, creating that knuckle joint. And in the short axis view, we can see the cross-sectional areas of these two tendons. And so the superficial structure again is the FDS tendon that overlies the FDP tendon over that metacarpal head there at the bottom. One thing to note is it's easier to differentiate these two tendon cross-sectional areas with dynamic movement, and so this can be confirmed by isolating flexion of the distal interphalangeal joint as well as the proximal interphalangeal joint. So when you isolate motion of the tips of the fingers, the FDP tendon will glide, and the FDS tendon should stay relatively still. And when you move the proximal interphalangeal joint, that middle joint in the phalanges, the FDS tendon should be the one gliding, and the FTP should remain relatively still compared to it. So now we're going to slide the transducer distally up the finger, and we are over the proximal interphalangeal joint or the middle joint of the finger. And the longitudinal view, you can see the middle phalanx meet the head of the proximal phalanx, creating that joint space. The FDS tendon still lies superficial at this point to the FTP tendon, but here the FDS tendon is going to begin to bifurcate, and each head of the FDS tendons are going to insert on either the ulnar or radial aspect of that middle phalanx. So you can gain a better appreciation for this in the short axis view. So on the right side of the screen, the FDS tendons are beginning to bifurcate or split off from each other, and that FTP tendon is going to remain at that bottom. If we were to slide the transducer more distally, we would begin to see the FDS tendons dip down dorsally in the hand out of view and insert on the lateral aspect of the middle phalanx. The FTP tendon is going to continue on and insert volarly on the distal phalanx. So the second part of our research project was to do an extensive dive of current literature regarding musculoskeletal sonography and tendon health. And so we wanted to see what sort of sonography parameters we can use to measure tendon health using both quantitative and qualitative measures. So some of the quantitative measures we'll be looking at are things like the cross-sectional area of the tendon, localized edema, neo or hypervascularization in the area, as well as tendon excursion, so how well the tendon actually glides. And we can view that with dynamic motion. And then some of the qualitative measures we'll be looking at are tendon gapping and echogenicity. So for tendon gapping, we'll be looking at this as either hypoechoic space between the two tendon ends where they should be healing, that increases with joint motion, or apparent lag between the two ends that happens during joint motion. So one of the tendon ends won't glide as smoothly as the finger is moving compared to the other end of the tendon. And we'll also be looking at gray cell intensity to determine in a certain region of interest whether or not the affected versus the unaffected hand are different from each other. So I'll give you a moment to look at this, and as well as the ICCs or kappa scores based on current literature. So after researching some of the sonographic parameters in the literature, we applied these measures to healthy participants as well as participants with surgically repaired flexor tendons. And so this slide will give you an appreciation for the differences that you'll see in healthy participants versus surgically repaired FTP tendons. So A and B, again, are longitudinal and short axis views of the FTP tendon. This is over the proximal interphalangeal joint. So that proximal phalanx is meeting that head of the middle phalanx, creating that joint space. And the FTP tendon is above, and it has nice elongated striations that seem very clear to view. And in short axis view, we can see that FTP tendon again, that cross-sectional area over the middle phalanx. In that area too, again, the FDS tendons not labeled here are going to start to bifurcate, so that's what it is above the FTP tendon. In contrast, below in images C and D, we have that longitudinal and short axis view again in that same area of a participant with an FDP tendon repair. In image C, you can see this X that the arrow is pointing to, and those are the core sutures that remain in that FTP tendon that are healing. The FTP also, you'll notice, will not have as clear and nice striations that span from the left and right side of the screen. You can also see more inflammation that's apparent in that area, as well as scar tissue and scar adhesions that are going to impede that tendon glide that you'll be able to see with dynamic motion. In image D, we're looking at the short axis view of the FTP tendon. And so the arrows are pointing to that cross-sectional view of the core sutures that you see on the in image C. And outlined in the circle is the cross-sectional area of the FTP tendon. And you can really appreciate the differences here between B and D, where the image in D shows a lot more inflammation, a lot less clear defined area surrounding the FTP, and that's due to all of that inflammation in that tendon space. The FTP above doesn't have nearly as much inflammation and has a lot more homogeneous tendon fibers throughout that entirety of that tendon. So we also applied Doppler ultrasound to look at the vascularity in the finger. And so the above image shows the vascularity in the healthy subject. And so just like we would expect to see, we did not have a lot of unexpected inflammation or a lot of hyper or neovascularity. We could just see the ulnar digital artery here that we would expect to see that runs along the ulnar aspect of that digit. However, in contrast, the participant with that surgically repaired FTP, you can see in this long axis view this presence of intratendinous neovascularity that's within the FTP itself. And so we also saw a lot more inflammation that surrounded that area that we picked up with the Doppler. And that is something that we were not seeing in healthy participants. So in conclusion, by establishing reliable and sensitive sonographic protocol to evaluate post-surgical tendon healing with precision and across time, we can improve clinical decision-making to individualize care, thereby optimizing outcomes for people with tendon laceration and repair. So for future directions, we hope that developing this protocol can serve as an exemplar for assessing other tendon injuries throughout the body, especially when evaluating them acute or post-surgically. We also hope that we can identify salient sonographic biomarkers that best indicate healing or healthy tendons, as well as best methods of analyses to evaluate and understand other musculoskeletal conditions. Thank you so much for taking the time to view our research. This study was funded by NIH NIAMS, the Society of Diagnostic Medical Sonography, as well as the American Foundation of Hand Therapy. If you have any questions or want to discuss the research further, please feel free to contact me at stakata@usc.edu. Again, thank you so much for your time.